Good day. Our topic for the day is digestive system pharmacology. Now, for the introduction, the treatment goals of your digestive tract drugs are to relieve the symptoms, to modify disease progression, and improve quality of life. The therapeutic targets include acid production, motility, inflammation, and microbial balance. So the common disorders in your gastrointestinal tract are the following. You have your GERD or your gastroesophageal reflux disease, your peptic ulcers, and your irritable bowel syndrome or your IBS. So there are specialized medications which target specific pathways within the digestive tract. So, as an overview for your pharmacokinetics, we know that it involves four um, steps. We have your absorption, distribution, metabolism, and your excretion. So again, as a review, absorption means the drugs enter your bloodstream through your intestinal wall. Then it will be distributed to your target organs and they are metabolized in the liver into active or inactive forms. And they are eliminated through your kidneys and bile. Now, as an overview for your pharmacodynamics, know your GI drugs, they interact with specific receptors in your target cells. So this triggers biochemical cascades that produce your therapeutic effects. And your GI drugs also affect your acid secretion, your muscle contraction, inflammatory mediators, and your neurotransmitter activity. And their strength depends on the binding affinity and maximum possible effect. So your properties of your GI drugs determine the dosing and treatment protocols. So as an overview, the classification of your GI tracts are the following. So we have your antacids or acid reducers. We have your probiotics, which is common nowadays for your as an adjunct for your treatment for your diarrhea. Then we have your laxatives for those patients suffering for your constipation. We have also your GI drugs, your antiemetics, which is to prevent your nausea and vomiting. And we have your antidiarrheal, so it reduces the frequency of your loose stools. Now, the first GI drug that we will discuss is your antacids. So your antacids um, chemically react with your stomach acid to raise your gastric pH. So once your gastric pH goes up, then there's a temporary relief with your heartburn or your indigestion. So the most common compounds used for your antacids is your aluminum hydroxide. And it is usually partnered with your magnesium hydroxide. Since aluminum hydroxide causes constipation and your magnesium causes your diarrhea, so they will cancel out their side effects. So that is why we have in the market aluminum magnesium. Then the effect of these drugs typically lasts 30 minutes to 2 hours. So repeated dosing may be necessary for your continuous relief of your heartburn. So here are the other examples of your antacids that you will encounter in the market today. So we have your calcium, your aluminum is partnered with your magnesium, and some also we have your calcium plus your magnesium. Another GI drug is your PPI or your proton pump inhibitors. So your proton pump inhibitors, the prototype here is your omeprazole. It irreversibly blocks the final step of your acid production since they bind to your proton pump enzyme in your parietal cells in your stomach. So when these drugs uh, bind to your proton pump, it will decrease or there will be no production of your hydrochloric acid, leading to acid suppression. So the effect of this drug lasts um, longer than 24 hours due to irreversible binding. However, in contrast to your H2 blockers, your histamine 2 receptor antagonist, it blocks your histamine receptors on your stomach cells. So this prevents your stimulating your acid production. So the H2 blockers, they last around 8 to 12 hours. So usually the timing of these medications in your pediatric is every 12 hours. In adults is every 8 hours because of the effects, which only last around 8 to 12 hours. So the most commonly used H2 blocker is your ranitidine. And now, let's discuss a little bit of your peptic ulcers. So your peptic ulcer, there's acid damage in that instance because there's an excessive acid which erodes your mucous lining of your stomach. So, coupled with your H. pylori infection or your Helicobacter pylori, which survive in the acidic environment in the stomach, it trigger inflammation and impair mucosal defense mechanism. And usually, your peptic ulcer is common in your patients who are also taking your NSAID because your NSAID or your non-steroidal anti-inflammatory drugs reduce the protective prostaglandins. So, um, decreased prostaglandin means there's increased susceptibility to your acid injury and it delays your healing. So that is your pathophysiology of your peptic ulcer. So there is acid damage, there's H. pylori infection, coupled with your NSAID intake. So the treatment of your peptic ulcer would have to target the three mechanisms of injury in your peptic ulcer. So we identify your H. pylori through your breath or stool test, and usually we give a triple therapy. So triple therapy means three medications. So we have your PPI or your proton pump inhibitor plus two antibiotics for 14 days. And we continue your acid suppression. We can use your PPI or your H2 blocker. And we can confirm your H. pylori elimination with follow-up testing either through breath or stool tests. And the reason that we discuss the disease peptic ulcer because this ulcer, if not treated, can cause your perforation, hemorrhage, obstruction, and in some cases, malignancy or cancer. So usually, we treat right away your patients with peptic ulcers with your triple therapy. So now, let's go now to your laxatives. So your laxatives are divided into your bulk forming. So it absorb water to increase your stool volume. It could be stool softeners. It could be osmotic. It could be stimulant, which increases your intestinal contractions. Or it could be your lubricant, or it coats the stool to ease the passage. So first, your bulk forming laxative. The most commonly used here is your psyllium. So it is a plant-derived fibers which absorbs water in the intestine. So they are considered the gentlest and the most physiologic laxative option. How about your osmotic? So your osmotic, by the name itself, it creates an osmotic pressure in the bowel. So it will draw the water into the intestine, softening the stool. So the onset is around 1 to 2 days. So the commonly used osmotic laxative is your polyethylene glycol. And also, some of your GI specialists would readily prescribe your lactulose as the osmotic laxative of choice. Now, for your stimulant laxative, so stimulant, it means that it stimulate your intestinal nerve plexus. So it will increases your peristaltic contractions and accelerates your transit time. So most commonly used stimulant laxative is your Bisacodil. The brand name is your Dulcolax. Other GI specialists would use your Sinocot or your Senna. And I have patients also who readily take in your castor oil as a potent options, occasionally as a stimulant laxative. And the risk for your overuse for your laxative, it can that your bowel becomes reliant on artificial stimulation. So since you are stimulating passage of stool, there's a risk for your potassium and sodium depletion. And hypokalemia and hyponatremia can cause impaired muscle function, and there will be malabsorption. So there will be a problem with your nutrition with your patient if you have if you happen to overuse your laxatives. Now let's go now to your antiemetics. So your antiemetics, it blocks specific receptors in the vomiting center. So this include your DOPA, serotonin, and your histamine receptors. So some antiemetics affect the inner ear balance center. So it helps prevent your motion sickness and your vertigo-induced nausea. So the drug classes for your antiemetics, we have your dopamine antagonist, which is commonly used, your metoclopramide. And for your serotonin antagonist, the most commonly used in the market is your ondansetron. And for antihistamine, we have your meclizine, usually given for patients traveling by sea, or with motion sickness. So your antiemetics in your motion sickness, we have your scopolamine. So this is an anticholinergic agent that works in the vestibular system. So it prevents your motion signals from causing nausea. So it can be given transdermally, lasting up to 72 hours. And you have your antihistamines, which block your histamine receptors, and it will reduce the sensitivity in your balance centers and vomiting pathway. So it is ideally given 30 to 60 minutes before the travel. And now for your antidiarrheal medications. So we have your opioid derivatives, anti-secretory agents, and your adsorbents. So the most commonly used opioid derivatives is your loperamide. So it slows your transit time and enhances your water absorption without central nervous system effects. And we have your adsorbents. Commonly used adsorbent is your bismuth subsalicylate. So it has a mild antibacterial properties, and it binds toxins, and it covers your irritated mucosa. And for your anti-secretory agents, the one being used in the market right now is your rasicadotril. So your rasicadotril, it reduces your intestinal secretions without affecting the GI motility. So It preserves your natural intestinal movement patterns. And what are the risks of your antidiarrheal overuse? So your antidiarrheal should be used with caution because it can mask serious infections. So that is why we seldom use your antidiarrheal if the cause of the infection is infectious because it may hide symptoms of bacterial enteritis. It can also prolong pathogen exposure, which is why we don't readily give anti-diarrheal because it might slow the elimination of infectious agents. And also, it can cause your toxic megacolon. So it is a dangerous complication in your inflammatory conditions, and it can also alter your gut motility. So one of the most often used adjunct for your diarrhea is your probiotics. So it is a very lucrative market right now. So in the market, we have your Lactobacillus reuteri, Bacillus clausii, Rhamnosus. So there are a number of your probiotics in the market today. So your probiotics are often used in your acute diarrhea because it can shorten the duration of infectious diarrhea by 24 to 30 hours. So it can also be of help for those patients having your antibiotic associated diarrhea. And it is also used in your irritable bowel syndrome. It also improves the bloating and pain for those patients suffering from your IBS. And it can also be used in your ulcerative colitis. It may help maintain the remission when combined with your standard therapy. So the challenges with your probiotics, because there are numerous probiotics in the market, benefits are linked to specific bacterial strains. So it depends on the uh, pharmaceutical company on how they test those strain. And many organisms die before reaching the intestine. That is why some probiotics needs to be in a cold environment. And there are also dosage uncertainty, and there are limited FDA oversight of quality and claims. Now, what is then the recommended diet to improve our GI health? So, we always have to instruct our patients to increase your fiber sources. So, sample of these, your whole grains provide insoluble fiber that adds bulk to your stool. And we increase the oral fluid intake of our patients, so at least 6 to 8 glasses, and we decrease the consumption of your processed food because it can cause constipation and inflammation to your patients and can be a risk factor for your colon cancers. And to take note also, when we are giving your PPIs, your proton pump inhibitors, we have to know also the long-term risks with the use of this. So, long-term use of your PPI, example of that is your omeprazole, is associated with decreased calcium absorption. So, we always advise our patient to increase their calcium intake if you are taking your PPI. And also, when taking PPI, evidence suggests that it can also increase the risk for your chronic kidney disease or your CKD. So we always advise them to have their annual checkup. Then also, using of your PPI in long term can also impair the absorption of your B12, iron, and magnesium because it reduces your stomach acid. So that is why it is imperative to annually monitor your blood chemistry. for your patients. And these are the some of the drug interactions for your GI medications. No? Your antacids, PPI, metoclopramide, and your sucralfate. So make sure that we know what are the drugs that needs um, to be given with caution with patients who are taking your GI medications. And for your pediatric population, we always adjust the dose of our GI medications based on the weight of the patient. Then we always advise and instruct the mother to report any side effects after giving your GI medications. No? And are also liquid preparations for your pediatric patients, and we always um, facilitate the intake of your syrup or your suspension for your pediatric patients. And for your elderly or your GI patients, and now let's talk about your liver disease and your GI drugs. So your liver disease impairs your drug metabolizing enzymes. It leads to your reduced clearance and potential drug accumulation. So that is why in patients suffering from your liver failure or those patients suffering from your hepatitis induced liver failure, we adjust the dose of your GI medications. So patients with hepatic compromise need regular liver function tests such as your SGPT and SGOT. So this helps prevent your toxicity from drug buildup. And these are your pregnancy safe GI drugs. No? So if your patient is pregnant, you have to avoid using your sodium bicarbonate. So you can use your Antacids, sucralfate, or your famotidine. For patients with constipations who are pregnant, we avoid your laxative. So we use your psyllium. And for nausea, we can give your vitamin B6 or alternative medication or herbal meds such as your ginger. And for diarrhea, we can use your kaolin pectin mixtures. And for your antibiotics for your GI conditions, we have your H. pylori eradication in your peptic ulcer disease. We can use your clarithromycin and amoxicillin coupled with your PPI for 14 days. So that is your triple therapy. And you can also give your bismuth as a quadruple therapy if there's resistance with your H. pylori. Now for your Clostridium difficile infection, we can give your vancomycin. For your traveler's diarrhea, we can give your ciprofloxacin or your azithromycin for severe cases. And for your small intestinal bacterial overgrowth, we can use your rifaximin since it has a minimal systemic absorption. And here are some of the herbal and alternative treatments. No? So we can give your chamomile for your abdominal spasms, peppermint oil to relax your intestinal smooth muscle, and we can use your ginger or luya. It can use for nausea and your gastroparesis. Now, in patients suffering from your pancreatitis, we can use your enzyme replacement therapies. So, your lipase, amylase, and protease, um, these are exocrine products of the pancreas. So, usually, in critical for your pancreatic insufficiency in chronic pancreatitis or cystic fibrosis, we can give your enzyme replacement for this one. And we can also have your lactase supplements. So your lactase supplements, it assists in breaking down your lactose in dairy products. And we can have your alpha galactosidase. which will digest your complex carbohydrates. So the timing with meals is crucial for effectiveness if you are going to give your enzyme replacement therapies. Now, for your anti-inflammatory GI drugs, your 5-ASA compounds or your 5-aminosalicylic acid, it reduces your inflammation in the colon. No? That is your mesalamine. So it works topically at the mucosal surface with minimal systemic absorption. Or we could use your corticosteroids. So it has an anti-inflammatory effect, especially for patients suffering from inflammatory bowel disease flares. Now, for your immunomodulators in your IBD, so your IBD is a group of inflammatory conditions of the colon and small intestine, such as your Crohn's disease and your ulcerative colitis. And one of the main treatment for this are your immunomodulators. So example of this is your thiopurines. So we have your azathioprine and 6-mercaptopurine. So it requires 3 to 6 months to achieve your full effect. Another immunomodulators in your IBD is your methotrexate. So it is effective for your maintenance after steroid-induced remission. And we have your cyclosporine. So it is a rapid-acting option for severe ulcerative colitis. And as a conclusion for your pharmacology in your GI system, we always instruct the patient on how to take in your GI drugs. So we explain on what to expect and when to report your side effects and your adverse effects. So we discuss the food, supplement, and drug combinations when taking your GI drugs. And we use reminders and technology to boost the compliance. Thank you for listening.